Everyone. I am so excited to be introducing our speakers today. We're very fortunate to have such great experts here at Nationwide Children's Hospital and a great topic that we've gotten requested a whole bunch. So very excited to learn along with you today. First, I'll introduce Dr. Casey Levy, who practices within the Division of Adolescent Medicine at Nationwide Children's Hospital. She completed her pediatric residency and chief residency at Children's Hospital of the King's Daughters in Norfolk, Virginia, before completing her fellowship in adolescent medicine in Columbus, Ohio. During her fellowship, she obtained her Master of Public Health from The Ohio State University, developing a passion for program development and upstream intervention. She focuses on high-quality evidence-based medical care for youth with eating disorders throughout the eating disorder spectrum of care. Next, I'll introduce Dr. Griffin Stout, who is the medical director of our eating disorders clinic here at Nationwide Children's Hospital. She completed her psychiatry residency at University Hospitals in Cleveland, Ohio, followed by her child and adolescent psychiatry fellowship at Nationwide Children's Hospital, and we are fortunate that she's stayed on since. So with that, I will turn it over to you two.
And Casey, should we start with our personal tidbit that we are birthday twins?
We could. No.
We were born on the exact same day, exact same year, different states, but we are birthday twins. So maybe that's part of why we work well together.
No. Can everybody see the slides okay too? Just to check in.
Yes, looks good.
Beautiful. Okay. So we're super happy to be here today. Griffin and I work together very closely, and so we're going to kind of tag team back and forth, and we really want this to be a useful presentation for folks. We, are very aware of how much pediatricians and providers are dealing with right now with kids with eating disorders and with maybe not eating disorders, but maybe other nutritional concerns. And so we're really excited to give this talk and, kind of help at least provide a little bit of a framework of how we think about things within the world, and hopefully it'll be helpful for you. But don't hesitate to pop questions in the chat, and then they'll let us know if we're there and we can work on it. So with that, I'm going to let Griffin go. Well, yeah, you go.
Yeah, so some of our objectives today is certainly we want to allow an opportunity to increase and help you all understand the diagnostic criteria for eating disorders. We look forward to talking about a bit about weight stigma and its impact on medical care. Casey will go into a great presentation about how to recognize malnutrition in an adolescent and evaluate medical stability, and really trying to maybe shift our focus on malnutrition, recognizing how to capture it, looking at malnutrition as an energy balance issue and not a body size or shape issue, and highlighting that malnourishment is not diagnosed by looking at somebody, and recognizing if they're in a larger body or a smaller body or a cachectic body, there are other measures to identify malnutrition. It's important to talk about malnutrition as it's so key in the diagnostics of specifically anorexia nervosa, but really talking about that malnutrition because it affects pediatricians, because you are the ones assessing the medical stability, and that it can so negatively affect, of course, medical stability, as you all know. So to kind of set the stage for our talk today, Casey and I would like to talk about something that we are very passionate about, and it is called health at every size. And ultimately, the take-home message of health at every size is what I was just touching on, that you cannot determine a person's size or determine a patient's health based on the size of body that they are in or the number that's on a scale. That the number that's on the scale or their weight is one factor, but it's not the sole indicator of health. That actually health is related to behaviors that include but aren't limited to having a variety of appropriate foods throughout the day, fueling our body consistently, having joyful movement, getting enough sleep, living in a safe environment, having, it does kind of touch on some of the socioeconomic and social determinants of health, but that all of those factors are actually what determines somebody's health, not their body size or shape. And I'm going to go out on a ledge saying that to about 75 pediatricians, because I know that as a psychiatrist, my training is different and my practice is different than yours. But I also recognize that as a pediatrician, often we're taught to look at BMI, weight trends, and to use that information as a determinant of health. And I'd like us to open our mind to think of it in a different way. There is actually a lot of scientific evidence and research that help support health at every size. One example of it is a population study, a meta-analysis, that actually shows that those who are in the overweight category have the lowest mortality overall, and that actually those who are underweight tend to have higher more negative outcomes and more health concerns. So I think often as physicians we're taught and practice that the more weight you lose, the better. But when you actually look at the science, potentially there's evidence that being even in that slightly overweight category is more healthy. And that actually even grade 1 obesity is not associated with higher mortality. And so it's something to, I'd encourage you, if this is interesting to you or shocking to you, ask us questions. This is something we'll talk about today. If you're interested, we've attached some of the resources, the Hayes curriculum, some things to think about. When we think about body size and shape, there are many factors that influence it. Genetics is one of them. Certainly activity level and diet do. And that the most crucial is having a balanced variety of foods, having that balanced and joyful movement that is not punishing, that is not repetitive, which can be harmful in other ways, as well as looking into environmental factors. Those who do not have enough financial resources, those who struggle with that, higher ACE score, can be in a larger body size and shape regardless of their dietary intake. There are many factors that determine our body size and shape that aren't just what we eat. Casey, more that you'd like to add to that?
Griffin knows me well enough at this point, I think, to know I'm always to chime in. I think we're going to talk more. In this work that I've done, I've seen a lot of patients, and we all became pediatricians and care providers because we love taking care of kids and we want them to be healthy. And the research that I've kind of gotten into lately, and that we'll share a little bit around things, is I think very important as a foundation for this. And we say that because recognizing that potentially some of the large scale efforts from a public health standpoint related to obesity, the more you dig into it, honestly, the more questions I've come up with than answers. And it's really hard as a physician, I think, to have that happen and to think about that. So, these are a lot of names. I'm so glad to see kind of the folks who are here, names that I know and have had patients come from. So I'm really glad to have folks here. And I think next we're going to dive in a little bit and talk a little bit more about the concept of disordered eating, which is a little different than eating disorders. And so I know Griffin and I wanted to kind of chat a bit about that to start off too.
When Dr. Levy and I think about disordered eating, there are so many ways it can present, and it is so prevalent in our society. Dr. Levy spoke about, the public health attempts to address the obesity epidemic. And in doing so, with other factors like social media, have inadvertently or advertently created a really strong diet culture. Our culture and our society believes as a whole the smaller body is the healthier body, believes that there are good foods and bad foods, believes that if you eat bad foods, you are a bad person, believes that people in larger body size and shape are at fault, are lazy, are eating too much. And so, in that sort of fearful, kind of like, kind of want to say fear mongering state, uh, many people will engage in disordered eating, fasting, skipping meals, skipping food groups. We know that when people are significantly undernourishing their body, that can lead to a restrict binge cycle. And so if you're underfueling all day, you had a really good day. I only had carrots and hummus and berries, and my God, I had the best day ever. But then I lost control and I overate and I ate, so much and so fast that I, went way beyond what I meant to. And maybe then I have compensatory behaviors such as self-induced vomiting or using diet pills or something to get back on track. I need to have another good day. That actually this disordered eating is prevalent throughout a lot of our society, but specifically in teenagers, especially after the COVID pandemic. There were many factors that fell together to increase disordered eating. Our culture as a whole is inundated with media such as this picture that Dr. Levy pulled up. Look at the two sides, right? So we have struggling dieters who are sad and like frumpy and like, my God, they had a donut and pancakes 2 days in a row. Like that's gonna make them miserable and feel terrible. And one bad meal and how bad that can affect their lives. Versus like the successful dieters who are in a tiny body and are so happy and energetic and look at them. And eat salads all the time and maybe have to not go out with friends because there's not a safe salad on that menu, or who are thinking constantly about, did I eat enough? Have I burned off enough? So saying all this, I just want you to be curious and think about, we've all probably engaged in disordered eating at some point, right? And the question is, when does it cross that line? When does it become a disorder? And we'll talk about criteria. But we know everything in moderation is important, including dieting. We want to have some flexibility. We want to have variety. And anytime there is significant shame or putting ourselves down or really perceptively down thinking, like that's when we might be crossing a line, or that rigidity into more of a disorder. So again, talking about, good foods, bad foods. Avocado toast. Look at how healthy I am. Look at how much better I am than eating a donut. Whereas calorically, they may be quite equivalent. But really, if you were really fueling your body and you ate that one donut and you felt satisfied and satiated and you moved on, great. What's actually so wrong with that? A donut correlates to carbs and fat, and we actually need all that to sustain our bodies. So again, we're inundated by all this. Books, eat this, not that. So much shame associated with our diet culture. Atkins, intermittent fasting. We as physicians are inundated with this as well. And the best diets to follow. What I'm here to tell you is, are these things in and of themselves inherently bad? I'm here to be curious that potentially these diets potentially greatly increase our risk for disordered eating disorders, and we'll talk about why that's so concerning. Casey, do you want to jump in?
I was just, was looking at this. This is a whole bunch of different, obviously different types of diets and things that I've both been told to recommend as a provider before, and I think really touted as great options, right? And so the last few, really looking at like the DASH diet and all of those things, are ranked as #1 diets. And so the other thing I wanted to point out, though, is kind of looking at it, these are the top 10. So it does end with sort of that WW or Weight Watchers and Ornish diet as well. And then when they look at even other diets people are following, these are the bottom 5, which I wanted to put on there because they're things I think we hear from our patients. I'm not familiar with the AIP diet. There were some that I learned that I was like, I don't know what this is, but Whole30, sure as heck I hear about. Keto diet, hear about that all over the place, right? And these are kind of on that list very low, and what at least even folks looking at the diet are kind of grading it at. And then the bottom 2 I actually hadn't heard of, the Dukin diet, which is pretty restrictive, it sounds like, and then the GAPS diet as well. So, I think recognizing that like our patients can find all of this information everywhere. And, we're going to talk, and, Dr. Stout's going to talk a lot about, the diagnostic criteria, but also who gets eating disorders are folks who tend to be perfectionistic and tend to be those who do everything we ask them to do as providers. And so I am a big Marvel fan. So with great power comes great responsibility, as Spider-Man would have us remember. And so I think really looking at it as it's our job, I think in a lot of ways, to help sort of stretch and be flexible. And, Dr. Stout and I just want everyone, I think, to have a firm foundation of all of the risk and benefits of everything we recommend, whether it be a diet, whether it be exercise, whether it be this or that medication, just like anything else. And so I think that in a lot of ways is sort of the foundation of this. But I do encourage you to look. I actually kind of went down a rabbit hole last night when I was looking at some of these diets and things like that too. But let's move on and talk a smidge about eating disorders in particular, because I think disordered eating is one of those pieces that you recognize more as you start to look for it. And then eating disorders are a whole nother animal. So we wanted to spend some time on those for sure today.
Yep. Because we know that disordered eating is very prevalent, as we've touched on, and the eating disorders are actually, gratefully kind of fairly low prevalence. Anorexia nervosa 1%, bulimia nervosa 1.5%, which is great. We don't want them to be higher, but it is, where is that line crossed? So a little bit about kind of the causes and risk factors for eating disorders in general. We know there's a genetic predisposition. We know that those with immediate family members with eating disorders are at higher risk of having it themselves. As Dr. Levy touched upon, there can be some personality traits and some psychiatric comorbidities, social anxiety, OCD. That type A perfectionist can be more consistent with anorexia nervosa, those with history of trauma, unstable family life, more likely to have bulimia nervosa or develop bulimia nervosa. And then as well, we talk about environment, which we're kind of touching on. Certainly we get lots of messages from family and friends, especially if you're in a larger body. You need to lose weight. What if you lost some weight? You might be better at your activity, at your sport. You could cut some time if you got toned, if you went to the gym some more. And then you add on our current diet culture, and this is really like the perfect storm right now for disordered eating. And again, having disordered eating is a risk factor for meeting full criteria for an eating disorder. So it can be a slippery slope. So when we talk about anorexia nervosa specifically, it's those 3 criteria. It is intentional restriction leading to significantly low body weight in the context of age, sex, developmental trajectory, and physical health. So Dr. Levy will go into more detail on this. There is no amenorrhea necessary to make this diagnosis. It is about malnourishment in the context of where somebody had been previously growing. So we are here to tell you, you can have anorexia nervosa in a larger body. You do not have to have a BMI below 18 to meet criteria for anorexia nervosa. And Dr. Levy will go into why. So you have that physical malnutrition related to intentional dietary restriction, as well as intense fear of weight gain. constantly thinking about what they just ate, what they're going to eat, feeling terrible about it, constantly worrying, and as well as having persistent behavior interfering with that weight gain. So, okay, I had the cupcake, but I need to run 5 miles, as well as a really negative body image and misperception of how they identify their body. So we regularly have kids with a BMI of 14 or 15 who absolutely believe they are the largest person in that room. It appears nearly psychotic and delusional, I'll tell you. Certainly, there's specific specifiers. You can have anorexia nervosa with binging and purging if you are malnourished, right? So it's really about that malnourishment that Dr. Levy will go into. I'd really like to hit this home. Anorexia nervosa is the second deadliest psychiatric illness. It just recently was surpassed by opioid use disorder, like just in like 2 years. It had been the most deadly illness for a long time. Not only do they die by medical complications, which Dr. Levy will touch upon, but suicide. They have a much higher rate of suicide, and it speaks to the quality of life. We were talking about it in the criterion. They are constantly thinking about eating. They're constantly worried about eating. They can't enjoy anything. You know, a comparison is to alcoholism. You know, theoretically, with alcohol, you can abstain from alcohol and survive. You can survive. Your body can survive without alcohol. We know your body cannot survive without food. And when somebody has anorexia nervosa, they are essentially at times being encouraged or forced to eat 3 to 6 times a day. And that is incredibly difficult for them. So this is a very deadly illness that you can recover from when it's caught as early as possible. And so that's where I encourage you today. One of your walk home messages is, if I see disordered eating, I need to be concerned. I need to be wary, because this can be a slippery slope to something that's very deadly. That's one of my take home messages for you today. When we talk about bulimia nervosa, there's episodes of binge eating, which is eating more than what most would eat, and you lose control, as well as the inappropriate compensatory behaviors, which can include self-induced vomiting, but also can include laxative use, inappropriate insulin use, diuretics, diet pills over the counter, exercise, all of those things that make up the criteria for bulimia nervosa. And often there can be a pattern of restriction, binge, purge. So even if they're eating really good through the day and then struggle with binges, be curious and have to ask about purging. Because people often won't self-disclose this. And we'll talk about some screeners. But we have clients who are often coming to us with purging, 14 times per week, maybe 5 times a day. That's pretty clear. Like, if we have that, you're pretty clear that this is a problem. But again, it's about asking about these patterns of behavior, the frequency with which they are happening. So binging and purging must happen once per week over 3 months to meet criteria. That negative body image as well. And again, they are not malnourished. So again, Dr. Levy's part of malnourishment will be critically important here. And then binge eating disorder in more detail. Those are clients who often have binge episodes where they're eating a larger amount than what most would eat. So Casey, feel free to jump in, but of what I recall, more than a pint of ice cream, more than a medium pizza. Those are the ones that stick out to me. They lose control while they're eating. They may become numb. They may sort of dissociate. They eat very fast. They eat beyond fullness. They're very embarrassed and guilty and feeling ashamed afterwards. Patients and clients will not come to you saying, I'm struggling with binge eating. They will say, I'm trying to lose weight, doc. I've been told I need to lose weight. How do I help lose weight? And often, if we're curious about their behaviors, we will find that restrict binge cycle. And the treatment for binge eating disorder is nutritional rehabilitation, consistent nutrition throughout the day. So the best thing you can do for them is recommend them to eat breakfast and eat consistently throughout the day. It's not when they come in to say, help me lose weight, doc, to say eat less, because all eating less does is fuel this problem. We'll hopefully have some time to talk a little bit more, but I want to make sure we get to the rest of what we have to talk about. And avoid restrictive food intake disorder. It is intentional restriction, but not to control body size and shape. It's often related to a negative or adverse reaction to eating. It can be choking, it can be stomach pain, it can be anxiety, it can be OCD, but it's not related to I want to be thin, I want to be small. So again, a little bit more about it. It's more common in males and females, often related to anxiety, and often tends to be a younger clientele. And they can suffer from malnutrition as well. So being really aware of that too. So for you guys, screening. Dr. Levy, do you want to jump in? You want me to keep going?
I'm okay either way. I think, I was doing actually a talk with Center for Healthy Weight, and really did a little bit of looking into some of the screeners, and they're no screener is perfect, but there are a bunch out there that are available for you, that you can use. These are some of them. The one that we used to recommend a lot, I feel like, is that SCOFF questionnaire. So I'll also admit I didn't really know what SCOFF stood for. I knew that like letters, but when I was looking at it, I was like, oh,
One stone.
I know, right?
One stone is funny.
One stone. So, thinking about, do you make yourself sick? Do you feel like you lose control over how much you eat or worry about that? Have you lost 1 stone? Is kind of one of the questions. And then other things about whether you feel fat or that you're too thin. People say you're too thin, or that food dominates your life.
And just to clarify, what's a stone? A stone is 15 pounds? 14 pounds. Thank you.
Yeah, in a 3-month period, which I just, anyways, thank you, Britton, for that. But I look at these, and the SCOFF questionnaire was really created within a population that had a higher risk for eating disorder. And so when they've done studies looking at it in like your general pediatric walking through your door population and adults, it's probably not quite as good as we thought it was before. So one of the ones that I wanted to also share with you guys today is this one. It's a specific screener for primary care for eating disorders. And it was developed in a way to help primary care providers have better tools to look for eating disorders. And it has crazily enough, 100% sensitivity, which is great, and about a 71% specificity. So pretty decent. And the way this one works is if you have 3 abnormal responses, you are considered to have a positive screen for eating disorders. Does that mean you have one? Not necessarily, but it's someone you want to have kind of heightened, I think, concern for. And it's a really easy 5-question one. So are you satisfied with your eating patterns? Yes or no. If you say no, that's an abnormal response. Do you ever eat in secret? If you say yes, that's another abnormal response. And then looking at, does your weight affect the way you feel about yourself? Does your family member, or do you have any family that have suffered from an eating disorder? And do you currently have or have had an eating disorder? I think those pieces give you really a good feeling for patients, and definitely something that is doable. I know primary care is already loaded with so many screeners. And I will say, I just looked through the USPSFT, all those letters, and they came up with insufficient evidence to recommend routine screening for eating disorders in primary care. So that's like as of a month ago with their recommendation. However, I do think for those you're worried about, like let's say you're noticing some concerns with changes in their growth or anything like that, this is a good, helpful one that lets you know if you need to dig in a little bit more, or if maybe things are okay, right? So this just gives you an extra layer of a quick something you can do in a very short visit, to really see kind of how kids are doing. Anything else before I move on to Griffin that you want to add about screening or anything?
Nope.
So if we talk about medical management for malnutrition, I always kind of throw this out there. And if anybody's kind of seen me talk before, I think the thing I always want folks to think about is really, I don't care what their diagnosis is. That's really Griffin and Dr. Stout in our therapy world, right? Like what their diagnosis is. I care a lot more about the piece that impacts their medical status. And so that really is kind of looking at specific behaviors rather than that diagnosis. And so when we categorize these, it's going to be concerns about malnutrition, so which typically goes with restrictive eating. There's no correlation between severity of malnutrition and how many physical signs or symptoms you have. It's weird, but it's true. One would think if you were more severely malnourished, you would see more of these signs, but I can't tell you that that is true. And I think also it's one of those reasons why it's very important to look more at growth, which we'll talk about in a little bit, rather than abnormalities on lab work or other investigation. I oftentimes hear people when they come see me that say, I just had labs and everything was fine, right? And when I have a patient with an eating disorder, I think a lot of times I really am very careful to help them understand that lab work abnormalities are not something I see in all of my patients. Some of the most severely malnourished patients I've had with the most complications and worst eating disorders never had abnormal labs. And that's even in the face of recurrent purging. Now, the body is just phenomenally good at compensating. In some ways, I wish it weren't as good because then we could be like, look, there's a problem. And we'll talk about why that's really important with this patient population. We also have to remember that there's likely differences in genetic makeup of how bodies express malnutrition. So maybe there's one kid or one family that has an extra sensitive kind of expression through bradycardia, or maybe they have more of a concern about their different hematologic kind of measures, right? And so those are the things impacted by even slight energy balance deficit. And so recognizing that not everyone who's malnourished looks the same. They all look very different, honestly. When we look at purging concerns, that's really going to be related to the type of purging you're using, right? Are you engaging in diet pill usage? Are you engaging in laxative misuse? Are you, using self-induced vomiting, which can have so many effects and things like that? And I think this is similar to many things in medicine. We got to get real nosy and ask folks what they're doing and do it in a non-judgmental, open kind of way so that you can really help kind of know what their medical concerns are. And for kids, this is similar to like when you have your conversations about sexual activity and we kind of say kick parents out of the room. I'll be honest, with both purging and binging, I find that those are very what patients consider to be shameful behaviors. And so they oftentimes will really struggle to tell you about them. So I know how busy primary care is, and I know you don't have a lot of time. And if with an adolescent, you can give them the space or allow them to have that individual time with you, you're likely to get better information that can help guide your care. And when we think about binging concerns, I think the things we know are like long-term impacts related to probably having your body be in a size that may be where it wouldn't normally be without disordered eating. And so I think really looking at these long-term, now you can have all these and not have binge eating disorder, right? And so I think that's the piece. It's really about looking at the individual patient, which for those of us in medicine, I think that feels really natural to us to think about a patient as an individual and not someone that we have to fit in a certain mold, right? That's why we always say, well, your disease didn't read the book. And I think that's very true in this case as well.
Can I just jump in for a quick second? I just want to highlight those concerns that happen around binging and obviously malnutrition and purging. I will tell you, sometimes in an effort to lose weight, people will engage in those behaviors. Duh, Captain Obvious over here. But if inadvertently, as a physician, we are praising somebody for weight loss while not being curious of the behaviors that are happening, we may be inadvertently praising disordered eating. You guys have a power here. And if we're only focused on the number on the scale, we may be missing something. And so that was my just headline. Go ahead.
No, it's totally true. I love to add that in and kind of have folks think about that too. Because, when Dr. Stout talks about that, that's things I've heard from actual patients, right? Yep. And I think, what I hold fast is that no medical provider wants to do harm to their patient, right? We all take that oath, but we all firmly believe it in our genes, right? Like we don't want to hurt people, we want to help. And so I think recognizing how that is possible to both be trying to help and to hurt in that situation, I think is,
Right.
again, with great power comes great responsibility. And so I did want to leave you to, there's a great report, it comes out usually about every 4 or 5 years, somewhere in there. So we're due for another one, but it's kind of affectionately known as the Purple Book from the Academy of Eating Disorders. And it does a great job of going through a lot of this information and giving you some really good solid tips on how to work with these patients in your office. And it's freely downloadable. So it just, as a thought, it's a great resource. I'm going to travel over now to an area that is a hard one to talk about, and one that I really feel, though, is very important in a talk like this. So weight stigma is something that I have been learning more about over the last year or so, as I've done a lot of learning about many stigmas, honestly. I know we all have been through a lot between 2020 and now, and really looking at this, I think we're all in that sort of introspection and probably trying to figure out how we can be hopefully the best versions of ourselves. And part of what I've really looked at with this is how much weight stigma likely impacts our patient care without us even realizing it. And I think it's really important to talk about in forums like this. So, you know, if we say, what is weight stigma? Well, weight stigma is really the social rejection and devaluation that happens to those who do not comply with the prevailing social norm of adequate body weight or shape. And I think in many ways, what we see is because of how weight stigma impacts our care, it actually may lead to the very outcomes we're trying to prevent and to help for kids. And so that's the other reason I feel like this is extremely important to talk about as a pediatric provider, so that you've got good information. So in studies, it's actually really fascinating to look at in the research, but weight stigma is actually likely obesogenic, so actually produces weight gain in our patients. We know that when they experience weight stigma, they have avoidance of exercise and they have increased eating, which are like the two things we're really oftentimes trying to work on, right? And it's really interesting to note that weight stigma experiences predict future weight gain and a risk of having a BMI classified as obese, independent of baseline BMI. And so that's weight stigma alone, and something that we definitely need to think about. We also know, and I think this one, gosh, hit me home because we do so much work with our trainees. In healthcare in particular, what we see is that healthcare providers have significant weight stigma against those in larger bodies. There's a reported reluctance to do pelvic exams. Physicians on a whole do not spend as much time with those with higher BMIs compared to lower BMIs. Health education that is provided by physicians is less in time quantity if you have a higher BMI patient. And patients know this. They report feeling that physicians would rather not treat them. They perceive themselves as being judged, and that their weight loss attempts, because they feel judged, are less successful. And within our own world, what we know is medical students with higher BMIs actually struggle with more depressive symptoms, alcohol use, and substance abuse because they're living in a world that has anti-fat attitudes around them. And so I do think that's not only impacting our patient care, but those of us as providers as well. I think the other thing that's really important to know, in addition to pervasiveness for this, is that we also know that weight loss is often counseled as a willpower issue, right? I do a lot of work with substance abuse as well with teens. And just like we know substance abuse really is probably not, it has nothing to do with willpower. It really is a biological remitting relapsing brain disease. Same thing for this, right? And so weight loss, as we counsel it, and we tell folks it's about willpower, it leads to self-blame and shame when that doesn't work, right? And so I guess the question that I have, and some of these things that I think about with this, knowing that it delays care, knowing that we do all this thing, you know, just some questions for folks to think about. You know, does our focus on weight loss lead to greater stigmatization and really undermine everything we're trying to do to make our patients well? And that's a scary question for me. I'm not gonna lie. And I think also, is this also why, like, pediatricians, primary care providers, public health officials, is this why we feel like we're like not making any headway related to rising obesity rates? Is it because the things we're implementing are actually causing more of a problem than that we're trying to prevent? And I think those questions are ones that I'm definitely stuck on. And unfortunately, or fortunately, you guys are here, so you get to be stuck on them too after we're talking about them. So what do we do? Well, and then I'm going to let Griffin talk because I know she's got stuff to say, but educating ourselves on weight stigma. What is it? How does it impact our care? Again, all of us got into this for the right reasons. So how do we support our patients? None of us want our patients to feel judged or to avoid care. Challenge what you thought you knew about BMI, weight, and genetics. The more you read, the more it's going to be probably pretty scary in a lot of ways. And I think things like, I'll give you a teaser. Go look up BMI. It was never created as a health status measure. It was created for a statistical experiment, basically, in Belgium. And it has very little diversity to it, very little benefit. And so I think a lot about all the things I get stuck between as a pediatrician from what the AAP wants me to do, and then also what I know as well, right? And so I think too, focusing on well-being and behaviors for our patients, and really approaching our patients with empathy and respect and humanity, and avoiding judging and automatic judgments and assumptions that we make. And it's so hard. I mean, I think we can do it. I really do. I have a lot of hope because we love our patients. And it's also a really challenging thing when it's built into the fiber of the medical system right now. So, all right, Griffin, go.
I will just add, I think at this I'm preaching to the choir. You as pediatricians understand guilt and shame is not anything that creates behavior change, right? So from a mental health perspective, in therapy, you can't shame somebody into changing their behaviors. And so, unfortunately, I think that's what we as physicians inadvertently do when we are preaching the health benefits of a lower BMI, that one might not be true, and two is ineffective. So I just want to hit that point home that Dr. Levy was talking about.
So what do I do? Well, when I talk to these kids, right, I remember in my evolution as a clinician, I've gone from, I don't want to talk about weight numbers because that's hard. So let's talk about BMI because it's a little bit easier. And now it's like, what do I talk about? If BMI is also not appropriate, which it may not be, that'll be kind of up to you to decide, I think, in looking at the evidence. But I really have shifted more to a model of talking about like an energy equation in our body and thinking about all the 9 million ways that kids' bodies put out and use energy is just amazing. And that really our only energy input is nutrition, right? And so really recognizing that imbalance. And when I talk with kids now, I do a lot of chatting about that energy equation. And I also talk a lot about what we can't see that our body is doing with the nutrition we're providing it. And so one of the things we know is, where does nutrition go? Well, probably about 60 to 70% is that iceberg we can't see. Okay. It's the thing that took the Titanic down. So when we look at that, we see that our bodies you're not going to see it. You're not going to know that your resting metabolic rate is X, Y, or Z. Yes, we can measure that, but do we do that? No, we really don't. And then we also know the body requires energy for digestion of food. So oftentimes when we're counseling folks a little bit about even like energy expenditures, we typically are living in this top little bubble, which is the movement part, right? The part we can see. And it's likely a very, very small portion of where our kids actually use energy. I always talk to kids about this because they have this false perception that if they decrease what they're eating and they exercise like crazy, all of a sudden they'll be able to have this huge shift in their energy balance. And really, you could exercise all day long, you're still only impacting kind of that top part of the pyramid of where energy goes with kids. And, I think it's really important because oftentimes when we have folks with eating disorders in particular, and especially if you're working with someone on that, I don't know if it's an eating disorder or not kind of spectrum, right? This is really looking at, where does our body use energy? Well, it uses it for many different things, and especially in adolescence, right? The body is growing and developing, and kids don't think about their liver or their lungs or all the other things in their body that really require energy. Like, they assume if they're not doing anything in a day that's like aggressively running a marathon, they're like, well, I'm not burning energy. So I tell them a lot, like, you're burning energy just breathing. If you laid in bed and breathed all day, you would require a lot of energy to fuel your adolescent body. And so I think helping folks understand too that there is a wide spectrum related to movement. There's our metabolic needs, there's general daily movement that also adds to that, and then there's exercise, and then there's other things too. So I think we oftentimes have exercise in our mind as one set thing, but there's really a lot of different ways to move our body. Now, why do I care about all this? I think in a lot of ways as a doctor, and I think I say that because, I'm sitting here telling you like BMI may not be great, and like, what do we do with all of this? Well, the reason that we do still need to have some of these measures, though, I think really is because we need to be able to pick up malnutrition in patients. And malnutrition, in some ways in the pediatric world, we're lucky. Adult malnutrition, not fun to diagnose. But kid malnutrition, we have a lot of measures, which is really helpful. And so if you look at this is kind of the most up-to-date information. It was put out by I have to read this every time, sorry, Academy of Nutrition and Dietetics and the American Society for Parenteral and Enteral Nutrition, the ASPEN guidelines. And that's really a whole bunch of GI doctors and dietitians and folks who got together. And they really told us, what means malnutrition in a teenage and growing body. And it can be related to BMI alone, it can be related to weight loss, and it can be related to decline of Z-score. It also can be related to inadequate nutrient intake. And so I think that's really important to keep in the back of our minds. I don't do that, by the way, in what I do, and I do this all day long, but dietitians are real good at that one. Now, before I send you out there talking about malnutrition with patients and parents, I want to really prep you, because I try to always warn providers if I'm going to send you into a battle zone. And I put these on here because these are direct quotes I have had from patients' parents when we've talked about malnutrition. And I think it just tells us how we view malnutrition as a society and how we don't recognize it always, right? The first one I love, for the record, fundamentally disagree with your diagnosis. He was a lawyer, so you go figure. But really looking at this, I think in a lot of ways, these are common things I hear. Well, they can't be malnourished because they're eating all the time, right? And it really is a combination of things that makes you malnourished. You could be eating kale all the time, and yeah, you're eating all the time, and it has very little nutritional density. So I want to go through some growth curves. All of these are kids who ended up in the hospital due to severe malnutrition, and their growth curves are all very different. So that's part of the reason I wanted to put it up here. These are all actual patients too. So this kiddo came in, and I think we would all agree, we see at the 12.5 year, right, we're well below the growth curve. This is for BMI. And what we really see in that is this kid meets criteria for malnutrition on all of them, right? We would all get that. This kiddo also had severe malnutrition and was in the hospital due to concerns about their energy balance and bradycardia. This kiddo was also in the hospital as well for the same reason. And again, we can see previously growing well above the growth curve and drop down a tremendous amount. And the helpful thing about this is pediatricians, we're told to pay attention to those growth curves like crazy, right? And so this really just follows that. Watch those growth curves. This is the only weight growth curve I put in here, but I did it for a specific reason. I did it because if you look at this growth curve, really we see more flattening than a true drop off. And that's something that we can really, really find in these patients that they just sort of stop growing. And that can also be just as harmful to the body as having significant weight loss. Now, you're in your office, you're trying to figure out what you do with these children when they show up. And I think the first job as a pediatrician and a primary care provider is to pick out who is stable and who is not. And so to do that, you need some information. Orthostatic vital signs are your friend. Become acquainted with them again if you haven't used them in a while. I love them. And really know that even for some of these kids, I always put this out there, sometimes they'll even do things to manipulate their orthostatic vital signs. So they may try to move around or shift their body or other things. And we always have them lay down for about 5 minutes and just say, I want you to rest and chill. And we do that because it gives me a estimation of their resting heart rate, right? It's not as good as overnight monitoring, but it at least gives me a little bit of an idea. Always looking at that growth history. And then if you have concerns for compensation, like self-induced vomiting or other things, or malnutrition, those are my typical labs I run, both looking for potential other causes for malnutrition. Sometimes I'll throw in that ESR. I look at thyroid for most folks just to make sure I'm not missing something. And sometimes I do hormonal workup as well. And then if I start to see any of this, really low heart rates, blood pressures, drops in orthostatic, hypotension, abnormal electrolytes to a certain degree, then I'm thinking hospital. And I would expect you guys, if you're finding this is a great PCTC call to ask so we can talk through it. And really looking at it, there's no hard and fast, right? You'll see you have a patient who has a 46 heart rate and like, you just are looking at them and you're like, this is not good. And they're cold in their hands and their feet because they're so clamped down, right? Like that kid may need to come to the hospital if they can't improve it. And then subjectively, when we look at this, I also need to think about that. Do we have someone who's going long periods without food or eating? And do we have any safety concerns as well? Can't forget the mental health part when we're dealing with eating disorders. I'm going to finish this up with one little nod to agnosia, which I had to learn how to say. But it's something that I think is a really important thing for pediatricians in particular to recognize. And I think this can be parental too, honestly. But for kids and parents, it's just a lack of understanding of like why people are worried about them. And how severe their illness is, right? Dr. Stott did a beautiful job talking about the mortality of anorexia. It's scary. And so when we look at this, I learn best for my patients. And I think a lot of times, sometimes I have to call my mom and go like, if a doctor told you this about me when I was a kid, would you be scared? And it's like as a reality check, because I'm like, this seems bad. And so I think what I recognize though is really oftentimes our patients just don't know who to trust, right? The eating disorder is there. We may sound scary. And these are what my patients have told me over the years. A patient who said, I learned I just can't trust my eyes, which is very disorienting. And then also I had the patient once I just popped in to say hi because she was in for a nurse only visit. And I was like, people are worried about you. How are you doing? And she's like, I know, I have no idea why everybody's worried. Like legitimately, she's like, I want to like crawl outside of myself and turn around and look at me because everybody seems scared and I feel fine. So I just don't get it. And that I think is one of the biggest challenges about eating disorders. Most of my patients, 95% tell me they feel great, even when they need to be in the hospital. And then we've talked a lot about weight stigma and other things. I'm just going to throw out there some terminology to think about how you use it and say it to patients. I never say weight gain. I say weight restoration for patients. It's the same thing. They know it. I know it. We're all on the same page and it's softer. It helps a little bit. When I think about higher calorie things, I usually talk about energy density. So packing a lot of nutrition in a small volume. And then I'll be honest, you're about to see the same word a whole bunch, but I don't say calories, good food, bad food, or junk food. Okay. My one mantra is no food has no moral or ethical value. It's just a combination of macronutrients. And just like you don't think 93 octane for your car is necessarily a better type of gas necessarily than 87, right? We don't look at the moral value and say that I'm really morally corrupt because I'm putting 87 in my tank. You say, oh my God, gas prices are super high. Let me put 87 in. Same thing for food, right? We don't have good or bad food. We should have food in different combinations and we all need a different combination. And then I hate the word healthy at this point in my life because I've seen it misappropriated to cover a whole host of concerning things. And so I throw that out there because I think when we say things like, well, I just want you to work on being healthier. Well, what does that mean, right? And I think just recognizing that when you have someone who has disordered eating or an eating disorder, they can interpret that in many ways that we would not consider healthy. So just making sure that you're checking in on how they're doing and how they interpret what you say. So we are going to run out of time, which always happens, but we are, I think, finished with our portion. And then I do have some stuff about BH tips too.
Okay, we did have one question come in through the chat. It's a good one. What do you do when parents minimize or fail to recognize the seriousness of eating disordered behaviors as they may be involved in diet culture themselves?
100%.
Yeah, this is a common one, right? To Casey's point of that I don't even know how to say it, but the lack of awareness in the illness can be a shared delusion with the kid and the child, and a piece of that diet culture having hold on us. And it is just about, one, checking in on yourself and your diet culture beliefs, and two, starting to educate the patient and family on the realities of what Dr. Levy has talked about: malnutrition, no good foods, bad foods, those sorts of things.
To recognizing the power of time and the influence you guys have as primary care providers with these kids and families.
Yes.
I think it's a really powerful message for someone who's known you since you were born to say, I'm worried about you, right? I am concerned about you. And I think recognizing that if you say that and you say, we need to work on this, right? And have them come back, that is really helpful for you to determine what's concerning and what's not, right? Kids may really be in a place where they can make changes that you ask them to make. And if they do, maybe it's not an eating disorder. Maybe they should know, right? Kids don't know anything about nutrition. And so I think in a lot of ways that helps you. And it's a wonderful commodity to have as a PCP, to have that time to figure it out. And I think just continuing to say, I'm worried, this is why I need to have you come back. I also will say, don't get bullied into telling parents that it's okay when it's not okay. I've worked with enough parents to know that they want you to say something that you may not truly feel is medically sound. And so I will oftentimes call that out and say, I know you feel like they're okay for soccer. I can't tell you that. And I just have to be upfront with you with that. I'm not soccer police. I say that a lot. Like, I'm not going to come find you on the field and take you off. And if I recommend no soccer, it's because scientifically and medically and physically, I think it's a bad idea. You guys still can talk at home and decide what you want to do. I don't come find you. So.
And I do think what Dr. Levy is saying highlights that last question that we just got. What are some of those red flags that set the stage for being more concerned? And it's, I've shared with you my concerns. We're still seeing weight loss or no weight restoration. Doing those screeners, asking about quality of life, asking about what eating is like, what body image is like, and if it's intensity, if it's often throughout the day, if it perpetuates significant guilt and shame, that's when you're going to want to be more curious that we're crossing that threshold. So those are some of the red flags I can think about. But Casey, I don't know if you have others.
I think, looking at those vital signs too, like, are you seeing changes? I trained where a cardiologist famously told us one time, do not call me about bradycardia until it's 0, heart rate of 0. That's all I care about for bradycardia. And I think in a lot of ways, what I really look at is that's probably a little too extreme.
I'm sorry, I'm going to have to process that, but go ahead.
It's true. But when I look at that, right, like, what is the change? Do you have a kid who was previously in one place and now all of a sudden they're like very low in that heart rate? I think looking at the average softball player in high school years is probably not someone who's out there at the level of an Olympian. So really, do we expect an athletic heart in that scenario? And I think helping parents and patients understand that you can have a low heart rate for many reasons, and it can be the same number. Sometimes that's good, and sometimes that's from bad stuff as well, right? Sometimes that's because we're not feeling our body well. And so I do think those pieces are really helpful for you to use, and just continuing to talk about it. If eating disorders don't vanish usually on their own, so if they're there, they're going to let themselves be known.
Well, on that note, let's shift real quickly to if people do need to consult and want to talk further about specific cases, a nice resource for them. And I think Kento is on the line with us. Kento, if you want to share.
Yeah, thanks for having me today. BH tips, maybe some people have heard, if you could click through, see, since we have a very little time. Really, our program is a virtual consultation with the child psychiatrist and CMC care manager. It's a 15-minute appointment. Really, the goal is to increase behavioral health access for primary care. That includes family medicine as well as pediatric practitioners. Next slide, please. So we have appointments Monday through Friday, 12 to currently 1:30, but generally 1 till 2 o'clock. Or if you have a specific patient where you have a question about, then you'll be able to set up a sort of a curbside, I think is the simple way to think about it, with a psychiatrist and a CMC to get a package, sort of a more comprehensive treatment recommendation for medication assessment, as well as any resources that care manager might have. You would fill out a short form about the case, and then at the end, you'd be getting a summary of what we discussed. So one of the example visits, 2 SSRI failed both, not sure what to do. And then in the visit, we discussed using Wellbutrin and or Buspar to kind of carry over during the cross titration to SNRI. So really, there's really no bad questions. If you have any questions about a case, I think BH Tips would be a really good resource. So well, we can't really check on referral or expedite referrals. Those are 2 things that we cannot do. And then there is a service, I think I heard PCTC earlier in the appointment. So I think currently it's called Physician Direct Connect. So every discipline, I think, has nationwide. The difference between BH Tips and Physician Direct Connect is that we have a case manager on the call. So they'll be able to provide some of the social work aspect. And then since it's a scheduled appointment, you won't be waiting for a callback. So that's one of the benefits. Now the call types, obviously medication management is the most sought after question, but we can ask any questions. And next slide, please. And because the medication and just question is the most commonly asked, obviously it's the most high response rate. And these are some of the consults that we've got. Common things being common: anxiety, ADHD, and depression. So those are the 3 of the most common diagnoses that's being asked. But we can ask any questions. And then I just wanted to highlight this one right here. It's pretty well received feedback. Those are not drawn to scale. It's actually drawn from 8 to 10. So it looks like it's really low, but it's really 8.8 right down there. So from scheduling visits to summary, it's been pretty well received. And then we track comfort level before and after consultation. A majority of the providers, as it's shown in the graph, feel more comfortable about managing the case after the consultation. This is also statistically significant. And I wanted to point out that this is a free service for any provider practicing in Ohio. And then patient does not get billed. So it's a free service, virtual. And then, so these are the counties of reach. So how do we get in touch with us? If you could Google NCH BH Tips, it'll be the first website on the Google search. There'll be a blue box on the right side, and then it'll take you to the scheduling.
All right, thank you so much for covering BH Tips, and thank you so much to Dr. Stout and Dr. Levy for your presentation today. It was very helpful, great information. Appreciate your time.